Good afternoon. We are going to get started. Welcome to today's webinar, Guidelines and Resources for Transitioning Adolescents and Young Adults with Spina Bifida to Adult Care, which is provided through a collaboration between the Pennsylvania Medical Home Initiative, a program of the Pennsylvania chapter of the American Academy of Pediatrics, and funded by the Pennsylvania Department of Health. This webinar, led by Drs. Decano and Haltro, aims to describe how the Spina Bifida healthcare guidelines can be used in clinical practice to identify at least two models of transition to adult healthcare for individuals with Spina Bifida and to determine which payment codes may be added to current billing practices. My name is Dr. Renee Turchi, and I'm a pediatrician at St. Christopher's Hospital for Children in Philadelphia and medical director of the Pennsylvania Medical Home Initiative at the Pennsylvania chapter of the American Academy of Pediatrics. This webinar is being recorded. The recording will be available on both the Pennsylvania Medical Home Initiative website and will be posted on the University of Pittsburgh Internet-Based Studies in Education and Research website. For CME purposes, please be advised that Dr. Haltro or myself have any disclosures. Dr. Decano has a relationship with the grant research work with the Centers for Disease Control and Prevention and the Pennsylvania Department of Health. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views nor policies of the Pennsylvania chapter of the American Academy of Pediatrics or its funders. Now please allow me to introduce Drs. Decano and Haltro. Dr. Brad Decano is an associate professor in the Department of Physical Medicine and Rehab at the University of Pittsburgh School of Medicine. He is also the director of the UPMC Adult Spina Bifida Clinic, medical director and COO of the Human Engineering Research Laboratories, medical director of the UPMC Center for Assistive Technology, and associate medical director and chair of the Professional Advisor Council at the Spina Bifida Association. His clinical care and research focuses on the prevention of secondary conditions in individuals with disabilities, especially spina bifida. He also holds a master's degree in bioengineering. Dr. Amy Haltro is a professor and vice chair in the Department of Physical Medicine and Rehab for Pediatric Rehabilitation Medicine at the University of Pittsburgh School of Medicine. She is also the vice chair for Quality and Outcomes. She directs the ACGME accredited Pediatric Rehabilitation Medicine Fellowship and is the chief of Pediatric Rehabilitation Medicine Services at the UPMC Children's Hospital of Pittsburgh and the medical director of the Rehabilitation Institute. Dr. Haltro is board certified in pediatric medicine, physical medicine and rehabilitation, and pediatric rehabilitation medicine. She earned her MD degree at Michigan State, went through the dual residency program at Cincinnati Children's Hospital for pediatrics and PM&R. While in residency, she earned her Master's of Public Health and Health Policy and Management from the University of Michigan. She joined the pediatric faculty at UCSF in 2005, and while in her K Award studying the family impacts of disability, she completed a PhD in medical sociology. She joined the faculty at University of Pittsburgh in 2012. We are delighted to have Drs. Decano and Haltro present on this timely important topic for primary care clinicians. I'd like to just give a personal note on Drs. Decano and Haltro as two people that I personally admire. As you can tell by their bios, they're incredibly accomplished. They've also been two champions that I've seen both in Pennsylvania and nationally do wonderful things for children. And it doesn't help that they're both also kind, funny, and really great people that I often say represent smart and normal. So with that, I want to thank you both for being here today and would love for you to begin your presentation.
Oh, Renee, thank you so much. That was a great introduction, and we love working with the Medical Home Initiative and you all as well. And thanks for everyone for joining us today. I see a lot of familiar names in the list of people who are attending, so it's great to have you all join us. Renee did a great job at giving information about our disclosures. I just want to mention that some of the funding that we disclosed provides support for the Spina Bifida Clinical Care Network, which we'll mention today, and also help us develop the Spina Bifida healthcare guidelines, which we'll also talk about. So our learning objectives today are first to talk about how we can use the new spina bifida healthcare guidelines in clinical practice, and we'll talk about some transition models that can be examples of how to provide transition programs in your clinics. We'll also look at which payment codes you can use to supplement billing, and then I'll provide some additional resources at the end. So we'll jump right into some background on spina bifida. We know that there's probably about 170,000 or more people with spina bifida living in the United States right now. Actually, most of the individuals living with spina bifida we think are adults at this point. Spina bifida is considered the most common permanently disabling birth defect and occurs in about 7 out of 10,000 live births. And so spina bifida is no longer what we would consider a pediatric-only disability, because people are living long lives and they're living into their 7th or 8th decades or more. My oldest patient right now is close to 90 years old. There's lots of problems with access to care for patients with spina bifida. Many adult providers aren't really familiar with spina bifida, so they don't really know what problems to anticipate. There's few clinics in the United States that serve adults exclusively, only a handful that we know about. Some individuals with spina bifida get their care through the multidisciplinary pediatric clinics, so they continue to get care in those clinics for their entire life. And the issue there is that sometimes they develop, obviously, adult problems, which some of the pediatric specialists may not be able to handle. So for example, if a patient underwent a surgery and they were in their 40s or 50s and they had a cardiac event, the hospital may not be able to support an adult individual in that type of setting. But in most cases, a lot of patients with spina bifida are discharged from a pediatric clinic and must find their own providers. But the problem with that is that there really aren't that many providers out there in the community, because most are pediatric trained and already affiliated with the multidisciplinary spina bifida clinic if they know anything about spina bifida. So that really creates a lot of gaps in care for our patients. I wanted to talk about a partnership that we had with the Medical Home Initiative, and we provided a clinic survey across Pennsylvania. This was done back in 2016, and we administered the survey to members of the Pennsylvania Medical Home Initiative at a conference, both on paper, and then we also did it online through the listserv. And we looked at some background demographics information of the people filling out the surveys, but also we wanted to see what their confidence and interest and education was in terms of available resources for the care of individuals with spina bifida. And I won't be able to present all the data today, but I wanted to point out a few interesting findings. We had over 67 participants who represented a variety of different backgrounds and a variety of different practice locations and distance from specialty care clinics. They also represented a variety of different types of practices in terms of community and academic centers and pediatric family or solo practices. And one of the questions we asked was, does your practice follow or refer to the guidelines for spina bifida care services throughout the lifespan? So this was the version of the healthcare guidelines that was published at the time, although it was quite old. The prior version was published in 2006. And a surprising number of individuals said that they weren't familiar with the resource at all. Many individuals were not sure if their practice follows or refers to the guidelines, and some said no. So only 14% of practices actually said that they did follow or refer to the guidelines. So our first objective here is to talk a little bit about how you can use the new healthcare guidelines. So I'm going to talk a little bit about those. Like I said, the third or prior edition was published back in 2006, and it had 14 sections that covered a variety of different areas of care. In 2014, the Spina Bifida Association and the CDC convened a steering committee, and they looked at the old guidelines and concluded that an update was really needed because they were outdated. And they recommended merging some prior topics, separating some topics, and renaming some topics. And they came up with 9 new areas that they thought that we should cover, including things like self-management, men's health. There was a women's health section previously, transition, physical activity, health promotion, a variety of different areas. And so we convened an oversight committee that involved our medical director, 3 of us who served as steering committee co-chairs. We had a patient advisory panel comprised of adults with spina bifida and also families of children with spina bifida, and also expert reviewers. And it was also led by individuals on the executive committee directly working at SBA. We had 24 working groups of individual members that were each chaired by an individual, and also we had consultants working at CDC. And so in all total, we had over 100 people working on the guidelines, and this was really an international effort. It spanned outside the United States. We conducted a literature review. We came up with clinical questions that we thought were important to answer based on our literature review, and we vetted those questions by the patient advisory panel to see if they thought that they were important questions that we should be trying to answer with research. We used consensus building methodologies to update the prior guidelines and build new sections of the guidelines. And then we took what we wrote and vetted it at our consensus meeting at the Third World Congress on Spina Bifida Research and Care. After we got feedback, we drafted the document, got expert review, and some things I wanted to mention about the methodology is that we used an accepted framework for disability called the ICF framework, which was published by the World Health Organization. And the guidelines are also, they also follow a lifespan approach. So they span from newborn to adult, and they were written for people who provide care to patients with spina bifida routinely, like in spina bifida clinics, but we also wrote them with the primary care physician in mind. So we provided a table here to talk about the different aspects of the guidelines. We've compared the 2006 sections of the guidelines to the 2018 sections. So this slide shows how the existing guidelines were reorganized into new sections. So it's available for reference. And this next slide shows the new versions that were developed and how those spliced out into new sections. The format of the guidelines involves looking at outcomes, which are what we wish to achieve if we provide good care and follow the guidelines. Clinical questions, which are the questions that were targets of the LIT review. The guidelines, which are the actual recommendations for care that are based on the literature review. And because literature is lacking in some areas, some of these guidelines are based on clinical consensus or what we think is best practice. And then we identified research gaps, which were important topics where research and clinical consensus are lacking, and really there's no clear direction for those items. And we identified areas that may be synergistic with the National Spina Bifida Patient Registry as well, so they may be sort of targets for research that we can do with the registry. Here's the link where you can download the guidelines in PDF format right off the Spina Bifida Association website. And some things I wanted to mention is that in future work, we're actually in the process of developing a smartphone app version of this so that it's available for point of care. We'll also in the future be developing a Spanish version and also a family-friendly version, because this version was really written for providers, so we want to have a version that is usable by patients and their families. And I want to talk just over a couple of different sections of the guidelines. One important section is care coordination, And so the literature points us to the fact that better care involves designating a person in your clinic who provides care coordination. And this section of the guidelines goes over a lot of different responsibilities and issues that the care coordinator can handle. Another section of the guidelines provides a lot of resources on transition, which is an important topic for us today. And we think that it's really important to designate a person in your clinics to oversee transition services and to realize that transition is not an event in one point in time. It's really a process, and it really needs to begin in planning stages around age 12 and ongoing until the patient actually transitions to adult care. And we provide a lot of information about what can be involved in that transition process and how to ready patients for that. Another important section is the sexual health and function section that goes over a lot of information that we should be providing and counseling patients about that often gets neglected. This is an important topic to our patients and families that they've voiced, and so we think it's really important to include in our clinic workflow. Also, there's a section on self-management and independent living, which provides a lot of resources as to how we can help our patients learn the skills that they need to live independently and what to do in situations where they may not be able to learn those skills. Now I'm going to pass it off to Amy to talk a little bit about different models of transition.
Thank you, Brad. That was wonderful, and thanks for teeing this up. So as Brad stated, there are lots of opportunities to look at different models of transition, and what may be available in your community may be different than what's available somewhere else. But what we want to highlight is the very important role of the primary care physician as the locus of the medical home with whatever subspecialties that are involved in the care of an individual with spina bifida serving as people in the medical home neighborhood. So it may be a very well-connected spina bifida clinic, or it may be individual subspecialty practitioners. And so we wanted to share with you 3 different models of transition that will take us from pediatric primary care to adult primary care. And then the first model is a combined pediatric and adult spina bifida clinic. So we alluded to this already. There are definitely benefits in terms of this model, but we'll also talk about some of the potential drawbacks. Another model may be to adult primary care and then to an adult spina bifida clinic. We'll talk about the benefits and drawbacks of that. And then the last one, which is not necessarily a model, but often how it ends up being, which is individuals with spina bifida transition to both adult primary care and multiple adult subspecialists because there isn't an organized spina bifida clinical program for them in the vicinity. So we're going to start off with that first model, which is a combined pediatric and adult spina bifida clinic. So certainly the continuity that an individual and their family gets is really quite an advantage. So their major medical providers that are part of that medical home neighborhood know the history. They know what's been happening. They have the records. They're just continuing to see that individual into adulthood. So there's not issues around transfer of records or needing to do a handoff. This is also something that patients and their families tend to feel very comfortable about. A lot is happening as young adults transition, and a healthcare transition, in addition to all of those other transitions, can be an incredibly stressful experience, especially for young adults and their families who've had a lifetime of care with a set of providers. But on the flip side, one of the things that we think is essential as we build towards autonomy in adulthood is that we develop young people's ability to participate more actively in their health care so that they can develop autonomy. And in a setting of a combined clinic where an individual has received care their entire life in that clinic, they may not be able to really assume the autonomy that they deserve. because they're used to a system in which the child, now young adult, and family did not have that set up with the young adult acting as the CEO of their care. And I think this really means that there are inherent challenges into navigating new roles and responsibilities. So especially when the team members are pediatric-focused team members. Flipping the switch to treating adults like adults can be very challenging for those team members. In addition, the youth and their family might be challenged by that shift of roles as well. And certainly the issue of not having experience, which we heard about before with adult-based problems, is problematic. We already know that adults with disabilities are not screened adequately for general health maintenance issues related to adulthood. And I think individuals with spina bifida who are receiving their multidisciplinary care in a combined pediatric and adult space are at risk for that being more of an issue. So another model, and this is the model that we have, we're very lucky to have here at UPMC, is a transition model to an adult spina bifida clinic. So the primary medical home may have already shifted or may be shifting. And additionally, care from the pediatric medical home neighborhood for spina bifida clinic is switching to an adult-based clinic. So as is in our system, we're very lucky that we have the same health system. So for us, it is very easy for us to transition information. Handoffs can be very smooth because of that. And oftentimes, if there is an adult spina bifida clinic, it's associated with a very large health center, which may have primary care doctors as a part of that network. And then both the primary care physician and the medical home neighbors can be in the same system, and that can really benefit communication. I think definitely this helps solidify the roles of young adults to really take over management of their health care as much as they can. And certainly the benefit is having adult providers with expertise in adult issues. But what can be a real challenge is getting the right or full complement of subspecialists providers in that space. And that's because the way healthcare is structured at pediatric hospitals and centers is often quite different than how it's set up in the adult space. And in fact, multidisciplinary clinics, which are quite common for children with disabilities, are quite rare for adults with disabilities. I do think that one of the issues is that even though we work hard on the pediatric side to prepare for transition, it can be quite shocking when young adults and their families enter a healthcare delivery system in which there isn't as much attention to coordination of appointments, arranging and scheduling imaging. Additionally, it can be very challenging to transition extensive records, especially if it's in a new health system. And I think both providers and youth and their families feel a loss when they lose continuity with providers, especially providers who may have been involved in their care basically for their entire lives, and sometimes even before the individual was born. The last one is when an individual with spina bifida is transitioning from a pediatric multidisciplinary clinic to just a group of subspecialists on the adult side that's not organized or coordinated around their needs. But the truth is, this is very similar to how care is delivered in the adult space for individuals with complex chronic conditions. And we know that many adults with complex chronic conditions get their health care managed in this way. It really certainly encourages individuals to take responsibility for organization and prioritization of their care. And one of the things that I think is a real potential benefit is it really helps solidify that primary care medical home as the hub or locus of care. It does require that that individual medical home be very active in overseeing and assisting, but it can be a major benefit to have really strong relationships with providers in the primary care medical home. Some of the disadvantages include really potential loss of access to expert providers because they're just harder to get to when it's not organized. And certainly this loss of care coordination can be exceptionally challenging. And we know that young adults with all types of disabilities are really delaying and foregoing care that would benefit them, in part because access is so challenging and navigating the health system is very complicated. There are definitely challenges with provider-to-provider communication. And when you're not located in the same space, it really makes sharing decision-making in real time exceptionally challenging. And that, I think, is one of the efficiencies that we get in multidisciplinary clinics. We're able to do real-time sharing of information, real-time discussion as a team, therefore real-time decision-making and recommendations. We also know that when young people with disabilities transition from pediatric to adult care, they tend to have worse health outcomes. And that is because of these things where they lose access to necessary providers, they don't have good care coordination, the system is incredibly hard to navigate, communication becomes a challenge. And so when we think about it, this model is certainly not an ideal model. Briefly, I'd like to just talk about the model that we are very lucky to have here in Pittsburgh. So our pediatric spina bifida clinic, which receives Title V grant funding, has multiple providers in the clinical space at the same time. So it is overseen by pediatric physiatrists. We have nurses, 2 nurses and 1 who is really coordinating that clinic. We are exceptionally lucky to have a PA that helps us with transition, who also works in the adult clinic. We have neurosurgery, orthopedics, urology, physical therapy, and occupational therapy. We also have a vendor for DME, orthotists. We have a data coordinator for our National Spina Bifida Registry project. And we're exceptionally lucky to have 2 types of services for individuals who are struggling with social needs, including a social worker, and then we are the home for the Health Law Clinic, which helps youth, especially those around transition, deal with issues regarding their IEPs and their age of majority issues, such as guardianship or assisted decision-making and that sort of thing. So we're exceptionally lucky to have those individuals. Also in the exact same space is our ability to get radiology and laboratory and other studies done, and we have nearby access to other subspecialists and clinics that are nearby, which means that we have a nice, not only do we have a nice hub, we also have the spokes of the wheel that help round out that care. And when we transition to the adult spina bifida clinic here, we are very lucky to have that works alongside our spina bifida clinic, our assistive technology clinic. And as you can see, there's a bunch of overlap for who's involved. So Dr. DiCiano leads that clinic, and the PA that I referred to, who's our transition PA, is in that space. We have the therapists. And in the spina bifida clinic, we have a personal trainer, peer counseling, our spina bifida association and registry project coordinator, orthotist, dietitian, with input from therapists and rehab engineers. Also with great access to same-day services such as radiology and laboratory services. And we have, similarly for the pediatric clinic, the adult clinic has Title V funding. But unlike in the pediatric clinic, there's other clinics such as the neurosurgery clinic and the urology clinic, orthopedics, and then all the other potentially necessary subspecialty clinics that aren't as tightly woven into the clinic, and so they are virtual members of that clinic. And one of the great things that we were able to navigate is having urology be able to do same-day scheduling. So they're basically not physically housed in the same clinic and clinic appointment, but they're able to be coordinated very consistently. I wanted to spend a little bit of time because when youth with disabilities are in your clinic, it can take a lot longer to deliver all of the pieces of care that you might be trying to deliver. And for individuals with spina bifida, we really want to be making sure that we're working towards care delivery that improves health outcomes. And we know that not everything can be done in a 15-minute primary care appointment, but there's a lot of things that as care gets more complicated that we could do to optimize our billing. So there are two pieces of recommendations, like of actual guidance. Just released is the 2019 Coding and Reimbursement Tip Sheet for transition from pediatric to adult healthcare. And that's from Got Transition and the AAP. And then also, there's a great set of coding information for care management, telephone services, and other non-face-to-face encounters through the American Academy of Pediatrics. And I'm just going to show you a few of these and kind of talk about why they might be valuable for you to consider using as you're coding, just to help you get a little more reimbursement for the time that you're spending. I'm going to use telehealth services as an initial example. So we know that telehealth is just going to become more and more common. We also know that this can be a potential way that individuals with spina bifida don't need to come for a face-to-face encounter, but may have enhanced care by getting telephone or telehealth services. And it is billable and is associated with RVUs. So on the far right-hand side is actually the RVU for value for each of those services. And sometimes it's not very much at all, but other times telephone E&M services can get you a substantial number of additional RVUs that you weren't getting before, even if they aren't reimbursed by the insurance company. If you're employed by a group practice that tracks RVUs or incentivizes that, it can be a way to boost your productivity. Another example that I think is very helpful is thinking about care management for individuals with spina bifida. And complex chronic services require multiple elements. It requires 2 or more chronic conditions that are expected to last a long time. They put you at risk for exacerbation or decompensation or functional decline. And that's very true of basically every individual with spina bifida. And it requires that there's this care plan that needs to be evaluated and put in place and then tracked. And so it can help pay for up to an hour of staff time or other health professional, and you can do this every month. And so it includes physician-level oversight or physicians that are overseeing other team members doing that oversight. One of the things that Dr. DiCiano does in his practice is really lay out in a somewhat of a templated form to document what needs to be documented to get these care management services covered. And so this is just bullet points of how his clinic thinks about that documentation. And it highlights what's happening in terms of the individual with spina bifida, their health condition, and it says that the team is doing all of these pieces of chronic care management, which then allow for appropriate documentation and then therefore appropriate billing and reimbursement. Another opportunity is care plan oversight, which is not exactly the same thing. It is when an individual is residing not in their home of their family, but are in a group home or in some sort of other services, or if that person is receiving in their own home, home care services. So a lot of the individuals who are more severely affected by their spina bifida will have pretty extensive home-based services. And this is also about the physician oversight of multidisciplinary care. And additionally, it requires documentation of all of these different aspects, but can be another tool for billing. I also think one of the real important values of the primary care medical home when thinking about care delivery around the time of transition is that there is this attention to preventative and behavioral health services, and that we're doing our efforts to be able to make sure that we're reimbursed for all of that great anticipatory guidance and all of the important self-management skill development that we're working on with our families. So there's additional billing for preventative health services, and that can be in the teen years while we're working on transition and then afterwards as well. And doing any sort of health and behavior risk assessment that, as long as it's an instrument that is scored and has been documented using that standardized instruments scoring, that itself is also something that can be very helpful in determining the care needs of the patients, but also in terms of just boosting a little bit more in terms of productivity. And if there is a behavioral health condition identified, then general behavioral health integration care management coding can be added. And many individuals with spina bifida have depression and or anxiety, and that's likely under-recognized in their care delivery systems, and an opportunity both to improve their health outcomes and well-being, and then also obviously an opportunity from a billing perspective if that care integration is occurring. And I want to spend a little time, because one of the things that Brad was talking about in relationship to what we are promoting through the guidelines about self-management and development of autonomy, and the importance of that for people with spina bifida and all individuals, but more challenging to really reinforce, especially for individuals that have more complicated health care needs, and potentially those individuals who also may have some cognitive impairments, is this time that we spend on education and training for patient self-management. And what I can tell you is that it may be the best person to deliver it may not be a physician, but it also, in fact, may be that physician engaging in training or delivery of education as well. The primary care physicians in particular are well respected and trusted both by their patients and their families, which means they have a special role in really helping families recognize the importance of having teenagers develop self-management skills and develop their autonomy, and then also help navigating exactly how to do that. So that can be on an individual patient basis, but some practices are actually doing group sessions where you bill differently if it's for a group. And that's a potential way to bring together patients who have similar experiences and educate them together. That can also provide them some peer support. And it may be a way that your clinic can optimize by delivering more services to more people in a group setting. And then this brings me to a set of codes that we use very frequently in pediatric rehabilitation medicine, because we do this very frequently, is that we have medical team conferences. And so this requires that there's an interdisciplinary team of professionals, and you can bill both for conferences that include face-to-face time with a patient and family, or you can also bill for services that are not including face-to-face time with patient and family. And for patients who have complicated care needs, really a coordinated team conference can be really very helpful in solidifying a care plan, and especially when that organization and care plan is set up, and then through a shared decision-making process, goals are set with the patient and potentially also with the family. So this is another way to both improve health and collaborations with other team members as well as patients and families, and also can really improve satisfaction because patients and families are engaged with goal setting in this way. And I think that for professionals, even when you don't get to see your other interdisciplinary team members face-to-face, having this connection can be a really rewarding part of practice. So I'm going to pass this back over to Brad to take over the conversation about additional resources.
Thanks, Amy. So we wanted you to come away with a lot of different tools that you can use right away after the talk, and hopefully you've received some of those already, but I wanted to throw in a few more. At Spina Bifida Association, we developed some resources that will support provider-to-provider communication. So let's say, for example, you are a primary care practice or a pediatric spina bifida clinic, and you're transitioning a patient to a different practice, and you want to provide information to that new practice about the patient. These resources will help you with that. The first is a medical summary document, which is basically a worksheet that if you fill out, it should hit most of the highlights of the important aspects of the patient's health issues that need to be communicated. There's also a cover letter, which provides a summary of spina bifida and some common issues in spina bifida in general, just if you want to provide some overview to someone who may not have someone with spina bifida in their practice. And these are available both through the Spina Bifida Association and also through the GOT Transition website. Additionally, I wanted to provide a lot of different opportunities for people who are interested in spina bifida to get more involved in the community. One way that you can get involved is by attending our upcoming meeting. So our next spina bifida clinical care meeting will be on from June 28th to the 30th in Chicago. And at this meeting, we'll be discussing a lot of really important topics that relate to this talk today. We'll be having a session on transition. I know that some of you on the call are also from some spina bifida clinics in Pennsylvania, and we'll be talking about a new partnership that Spina Bifida Association is going to form with some of those clinics, which you may be really interested in. So I would encourage you that if you have the time, please attend the meeting and reach out to us if you have questions about it. The Clinical Care Partners Initiative that I mentioned is an initiative through SBA where we're going to try to see if we can designate some clinics as those that provide best available evidence-based care. And we'll have an application process for it, which involves providing some evidence about the different types of care that you provide and the services that you have available. And so we'll be talking a lot more about that initiative at the meeting. But on this slide are some issues that we will consider in that Clinical Care Partner Initiative. Also, I talked earlier a little bit about the research gaps that we identified in the healthcare guidelines. So if any of you are part of research teams, we want to look at some areas within the guidelines that have been identified by patients and also clinicians and researchers as areas of important research priorities. So we have those gaps that are identified by the guidelines. We have priorities of people living with spina bifida, and we have research that can be done easily with some of the data we're already collecting with the National Spina Bifida Patient Registry at many sites. And so where those overlap is really high priority research because it's important, and also it can be done with some of the data that we already have. So we want to have ongoing discussions about how do we prioritize and get some of those studies going so that we can add to the body of knowledge that we have already. I provided a link on this slide to the National Spina Bifida Patient Registry site if you're not familiar with it or want to learn more about it. There's also ways that you can get involved with the Spina Bifida Association. You may want to, if you're not already listed on the Spina Bifida Association website as a clinic, please contact us at the Spina Bifida Association so that we can get your information up there. Many patients throughout the country contact SBA and want to know where they can receive care, and if SBA doesn't know about you, the patients may not know about you. And I know that there are providers in Pennsylvania who are not on our website, so that would be great to update. You can also get involved with your local Spina Bifida Association chapter. Now I know there are some Spina Bifida associations in Pennsylvania that aren't officially affiliated with SBA, but there are some local organizations that do provide resources. The chapters that are affiliated with SBA are all listed on the SBA website. Another great resource is the professional listserv. Many people don't know about it. It's basically an email group that if you have a question about how do you handle a certain situation or a difficult patient issue, or how do you access a resource, you shoot a message to the listserv and people will chime in and really help out. And it's a great way to get resources, but I also find it a great way to learn what other people are doing, and I've learned a lot just by seeing the care strategies that people talk about. Finally, you can also get involved at the national level. There's lots of things that we can do in terms of advocacy to change the way that we have access to health care for patients with spina bifida. And so one example is our Teal on the Hill event, which is a national advocacy issue in DC. I also provided you some information on how you can build your own transition program. Got Transition is just one model. There's many out there, but Got Transition has a lot of different resources that will help you get started out if you want to build a program. And Got Transition talks about how to put 6 core elements into place. It's important that you have a transition policy. It's important that you have a way to track and monitor the patients that are going through transition. A way to assess whether patients are ready to transition and what you need to address before they do that. Some resources for transition planning, processes for transfer of care, and how do you document and close the loop that transfer has been complete. There's lots of different resources there for how you can put those processes into place. And there's also measurement tools, so you can take a quiz and find out how well your clinic is doing on those things and what you could do to improve. That's all I have for references and resources, so I think we have a few minutes left for questions.
Thank you very much. For folks that are on the phone, you hit *#6 to unmute your line. Those on the computer, you type in the Q&A box. Again, you can type in the Q&A box, or you can hit #6 to unmute.
Brad and Amy, I know you guys do some, this is Renee, I know you guys do some outreach to some of our areas in Pennsylvania, you know, for children who don't have access to some of the children's hospitals, and many of our pediatricians. I think this webinar was fantastic, and I think that, you know, it's really helpful, I think, for many of our colleagues in the Medical Home Network, because some of us are in areas where there are, you know, Spina Bifida clinics as yourselves. I mean, you guys have like sort of the dream team of transition, and I think a lot of the resources you provided us here with billing are really helpful. For folks that are in areas where, you know, maybe there aren't Spina Bifida multidisciplinary clinics, and they're managing a lot of this, I mean, do you guys recommend that they get, you know, to Pittsburgh or Hershey or Philadelphia at like a minimum? I mean, I know there's guidelines, or is there anything that, you know, anything that you recommend, kind of thinking about, you know, about the varying, you know, access issues?
That, Renee, is a great question. This is Amy. I think that it is very challenging for some families to navigate the distance, especially for families when that requires them to take potentially more than an entire day off of work. They're taking the family's only vehicle away. They may be feeling very stressed financially about taking time off of work. And so we certainly understand the constraints that families face and individuals face, but we do recommend at least a periodic assessment in a clinic where care can be reviewed and recommendations can be made. And almost all of the time, those recommendations are carried out in communities. But it does worry me that when we lose children to follow-up and we see them, you know, maybe a few years later, and they've been struggling with issues that we may have been able to help intervene upon. So any pediatrician who has questions, or primary care physician who has questions about how to navigate a clinical situation, we're certainly available. Our clinic is available by phone to help discuss those things and try to troubleshoot them. But we do often then recommend the trek to a subspecialty clinic to try to get those care needs addressed. It can be exceptionally challenging to do that, and so we know that even though we might want to be following them up on an every 3 to 6 to year-long basis, sometimes that's not possible. And so sometimes we arrange for more episodic appointments and then troubleshoot in between.
And one thing I wanted
to
add,
Go ahead.
sorry, I just wanted to say one thing I wanted to add was that one of the great resources that the specialty care grants through the Pennsylvania Department of Health offers through the Title V funding is that we can offer patient assistance funds which are aimed towards reducing barriers to care for patients. So if there are barriers like transportation, for example, that prevent a patient from getting the care that they need in a spina bifida clinic that's in one of our specialty care practices, those funds might be available to help those patients reduce those barriers and get the care they need.
That's great.
How would someone know about that, Brad? Is that like they have to come to you guys to get access to that?
They, yes, they would have to have a visit in our clinic, but we can walk them through the process of applying for that in any of the specialty care practices within Pennsylvania.
Maybe one of the things we could send out, and I think we're working on updating some of the resources on our website, but we could send out to this group and maybe make sure we have on the medical home website, you know, all the various spina bifida. Maybe you and Amy could just kind of make sure that we have all the listing of where folks can go depending on where they are in the Commonwealth, or just so that our medical home practices can look and see who's the closest or something like that.
Yeah, I think there's definitely opportunity to, you know, develop a map and some resources for where some of those clinics are. Like I said, the Spina Bifida Association website has some of that information, but I can tell you that there's practices out there that that we don't have yet on that website.
Great. We have a couple more questions. Someone is asking, do you have families that have been through transition who would be willing to talk with families of younger patients to support these families as they begin to think about transition, sort of like a parent-to-parent group?
What we have on the adult side right now, we have a person who works in our clinic who has spina bifida and went through transition, and she's trained as a peer counselor. So from the patient advocacy side, we have somebody who would serve in that role. I don't have anybody who, you know, in name works for the clinic or volunteers specifically who's a parent, but I'm sure that, you know, we could identify somebody like that who would be willing to speak to other families. I think that's a great suggestion.
That's great. We'll follow up with that. Another question is, someone just wanted to comment that I think you hit on the nail on the head with the transition topic. I am the medical home care coordinator and have an 18-year-old son with a L3 myelo. We have had to pave the way for our small rural practice to transition his care and education.
Well, thank you for that. We really appreciate it. We recognize both from the provider standpoint and how the health system is set up that transition can be particularly challenging. And then on the family and individual child/young adult side, there's a lot that goes into that requires a whole bunch of learning and self-esteem and self-efficacy and autonomy development that happens at a really challenging time in people's lives. And so it is an exceptionally challenging endeavor from kind of all perspectives, and one that we know as a health system that we could be doing better.
That's great. I just want to remind folks, if there's any more questions, hit #6 if you're on the phone, or there's a Q&A box. If there's no more questions, Dr. Turchi?
No, it doesn't sound like there's any more questions, so I want to again extend a very warm and sincere thank you to both Dr. Decano and Dr. Houtrell for this excellent presentation, and for all of you for participating today. This will conclude our webinar, and we also want to thank the Pennsylvania Department of Health for the funding that made this webinar possible. Thank you, everyone.